Thank you, sir. Good morning, everybody. My name is Dr. Kadir, and my topic is coagulopathy in pregnancy. First topic is postpartum hemorrhage. Postpartum hemorrhage is a severe vaginal bleeding after giving birth. PPH is the leading cause of morbidity and mortality in childbirth. PPH occurs in approximately 1% to 6% of all deliveries. Uterine atony, the primary cause of PPH, accounts for 70 to 80% of all hemorrhage. PPH usually occurs within 24 hours of childbirth, but it can happen up to 12 weeks postpartum. It also occurs due to severe vessels of the remained placenta and also the uterine vessels. Traditionally, PPH has been defined as more than 500 ml estimated blood loss in a vaginal delivery or more than 1000 ml estimated blood loss at the time of cesarean delivery. This was redefined in 2017 by the American College of Obstetrics and Gynecology as a cumulative blood loss of more than 1000 ml with signs and symptoms of hypovolemia within 24 hours of the birth process, regardless of the route of delivery. Primary PPH is bleeding that occurs within the first 24 hours after delivery, while secondary PPH is characterized as bleeding that occurs 24 hours to 12 weeks postpartum. The causes include primary uterine atony is the most common cause, genital tract lacerations, retained placenta, uterine inversion, abdominal placentation, coagulation disorders. Secondary include retained products of conception, infection, subinvolution of the placental side, inherited coagulation deficits. Hemorrhage leads to reduced circulating blood, which also reduced cardiac output. So it increases renin-angiotensin aldosterone is released, causes oliguria. Reduced cardiac output causes hypotension and reduced tissue perfusion, leading to anaerobic metabolism, which leads to acidosis, hyperkalemia, toxic metabolites, which leads to endothelial damage, DIC, and tissue death. When there is hypotension and there is reduced tissue perfusion, baroreceptors are stimulated, increased sympathetic stimulation is there, and also cardiovascular system. It causes vasoconstriction and increased heart rate and causes increased contractility. Vasoconstriction leads to increase in BP and increase in venous return. Signs and symptoms include there is a drop in BP like dizziness, blurry vision or feeling of faint, confusion, increased heart rate, decreased red blood cell count, pale or clammy skin, nausea or vomiting, worsening abdominal or pelvic pain. The risk factors are multiple pregnancies, twins or triplets or more, birthing a large baby, too much of amniotic fluid, C-section, oxytocin to induce the labor, general anesthesia, tocolytics to stop labor, prolonged labor, infection during labor, tearing of the perineal lacerations during vaginal delivery. PPH in prior delivery is also a risk factor. Other risk factors include high blood pressure or preeclampsia, infection, blood clotting disorders or other blood-related conditions, intrahepatic cholestasis of pregnancy, anemia, obesity, advanced maternal age, history of 5 or more previous deliveries. The evaluation can be done as there's a soft, boggy, or non-contracted uterus is the common finding with uterine atony. Widespread bleeding, such as from venipuncture sites, is a sign of disseminated intravascular coagulation. Laboratory studies can be ordered in a PPH to help evaluate and manage the patient, although interventions such as medication or blood product administration should not be withheld, pending the results of such studies. Coagulation studies and fibrinogen will be useful in the patient where DIC is suspected. The treatment and management of postpartum hemorrhage are focused on resuscitation of the patient while identifying and treating the specific cause. Maintaining the hemodynamic stability of the patient is important to ensure continued perfusion to vital organs. Ample IV access should be obtained. Careful direct assessment of cumulative blood loss is important. If the PPH is due to the uterine atony, treatment modalities include medical management with uterotonic agents, uterine tamponade, pelvic artery embolization, and surgical management. Medical management with uterotonic and pharmacological agents is typically the first step if uterine atony is identified. While oxytocin is given routinely at the time of delivery, additional uterotonic medications may be given with bimanual massage in an initial response to hemorrhage. Commonly used uterotonics are oxytocin, methylergonovin, carboprose, misoprostol. If bimanual massage and uterotonic medications are not sufficient to control hemorrhage, uterine tamponade may be considered. Uterine artery embolization may be considered in a stable patient with persistent bleeding. Fluoroscopy is used to identify and occlude bleeding vessels. While the unstable patient is not a candidate for this modality, it has the benefit of uterine conservation and possible future fertility. Exploratory laparotomy is typically indicated in the setting where less invasive measures for PPH have failed. This is a fluoroscopy image showing the bleeding vessel in the uterus. If the uterine inversion is the cause of PPH, steady pressure with a fist is usually used to place the uterus in the correct position. Uterine relaxants such as halogenated anesthetic, terbutaline, magnesium sulfate, or nitroglycerin can be used during uterine repositioning, with oxytocin and other uterotonics given once the uterus is in normal anatomical position. Occasionally, surgical correction of inversion may be undertaken via laparotomy. If a coagulation deficit exists, blood factor and product replacement may be used to correct the deficit. In a series of controlled studies on PPH in vaginal deliveries, tranexamic acid proved capable of reducing the extent of peripartum bleeding and time of hemostasis. Similarly, administration of tranexamic acid in the course of cesarean sections resulted in a reduction of bleeding time and blood loss, and in some studies of transfusion needs. Tranexamic acid for the management of hemorrhage. If the PPH is diagnosed, tranexamic acid 1 gram IV within 3 hours of delivery can be given. If there is continued bleeding, administer second dose within 24 hours. Do not exceed 2 grams in 24 hours. Risk of renal cortical necrosis or seizures are there. For PPH, prophylaxis may be given prior to delivery, given to patients with hemophilia, von Willebrand disease, and platelet disorders. Can also be given postpartum to prevent bleeding, 1 gram per oral TID. Insufficient evidence, there is insufficient evidence to give for primary prevention. It does not cross placenta and is found in breast milk, but there are no adverse neonatal outcomes have been demonstrated. There's a women trial conducted, effects on this tranexamic acid, effects of early tranexamic acid administration on mortality, hysterectomy, and other morbidities in women with postpartum hemorrhage. This is an international randomized double-blind placebo-controlled trial. 20,000 women with diagnosed PPH were enrolled from different countries. There was a significant decrease in death due to bleeding. Hysterectomy rates did not change though. Death from all causes did not decrease. No increase in adverse outcomes with tranexamic acid, that is venous thromboembolism. There was another trial on tranexamic acid, CRASH 2 trial. This is an RCT conducted in trauma patients. Tranexamic acid given within 3 hours of trauma decreased mortality. Tranexamic acid given more than or equal to 3 hours after event did not improve outcome or survival. It also can be given in cardiac and ortho patients. In the event of life-threatening hemorrhage, replenishment of clotting factors through off-label use of prothrombin complex concentrate, activated prothrombin complex concentrate, or recombinant activated factor 7A may be considered. However, the effectiveness of prothrombin complex concentrate or activated prothrombin complex concentrate is not demonstrated in clinical trials, and because of conflicting data, no consensus is available for treatment protocols or dosage. ProCoag trial, it's an RCT conducted to know the efficacy and early administration of 4-factor prothrombin complex concentrate in patients with trauma and risk of massive transfusion. There was no difference in total 24-hour blood product consumption among patients with 4 plasma prothrombin complex concentrate versus the placebo. Further, more thromboembolic events were occurred in the prothrombin complex concentrate group. The role of factor 7. Recombinant activated factor 7 is a hemostatic agent originally developed for the management of bleeding in hemophilia A and B patients with inhibitors to factor 8 and 9 respectively. Recombinant factor 7A involves in extrinsic clotting pathway where it forms a complex with tissue factor which in the presence of calcium and phospholipids activates coagulation factor 10, which then initiates the conversion of prothrombin into thrombin at the site of injury. Recombinant factor 7A is a vitamin K dependent glycoprotein that is an analog of the naturally occurring protease. In 1999, the US Food and Drug Administration approved its use of the treatment of bleeding episodes in patients with hemophilia and in patients with factor 8 and factor 9 inhibitors. The success of recombinant factor 7A in controlling hemophiliac bleedings has led to its use in non-hemophiliac patients with active bleeding and as a prophylactic agent for high-risk patients with obstructive bleeding, hemorrhage associated with warfarin toxicity. Recombinant factor 7A also reduces cost of therapy and use of blood components in massive PPH. In cases of intractable bleeding with no other obvious indications for hysterectomy, administration of factor 7A should be considered before surgery. Efficacy and safety profile is the most important concern of a hemostatic drug like factor 7A. Due to its metabolism action, factor 7A can lead to thrombotic complications such as myocardial or cerebral ischemia, deep venous thrombosis, or pulmonary thromboembolism. Early experience and dose-finding trials of factor 7A have suggested that a dose of 90 to 120 mics per kg confers adequate hemostatic effect for most surgical and non-surgical bleeding. Doses of 60 to 90 mics per kg have been used with efficacy between 80 to 87% in serious bleeds and 91 to 94% in surgical bleeding. However, there is ongoing controversial evidence regarding thromboembolic complications and survival benefit of the off-label use of factor 7A in massive bleeding. Use of factor 7A should be based on sound clinical evidence to balance the risk, benefit, and cost if used among non-hemophiliacs. Prospective randomized studies are needed to investigate the efficacy and cost effectiveness of factor 7A for this investigation and to allow a final assessment of the importance of this treatment. Role of thromboelastography. TEG provides a global assessment of hemostatic function and has been recommended to monitor potential coagulopathies during pregnancy in which hypercoagulable state is favored. TEG provides the real-time diagram of coagulation ability and records the formation of original clot, platelet activation, and production of fibrin protein. Among the 4 TEG parameters that are commonly determined in clinical laboratories, reaction time measures the time interval from the start of the test to the initial detection of the clot. TEG assesses global hemostatic function and is sensitive to coagulopathies. The clot strength is measured by 2 parameters in TEG, K value and alpha angle. Both of the K value and the alpha angle represent clot kinetics and mainly depend on fibrinogen levels. They can help identify states of hyper or hypocoagulopathies. Maximum amplitude is a measurement of maximum clot strength and gives information on both fibrinogen and platelet functions. TEG has emerged in many settings as a reliable means to urgently assess coagulation status in pregnancy. Variations of testing results between healthy and abnormal pregnant women were observed in one study. TEG may provide more accurate experimental basis for monitoring coagulation functions, especially in pregnant women with complications of gestational hypertension and preeclampsia. Thromboembolic disorders. Rudolf Virchow postulated that status, local trauma to vessel wall, and hypercoagulopathy is predisposed to venous thrombosis. During pregnancy, the risk for each increases. Compression of the pelvic veins and inferior vena cava by enlarging uterus renders the lower extremity venous system particularly vulnerable to stasis. There is a 50% reduction in venous flow velocity in the legs that lasts from the early 3rd trimester until 6 weeks postpartum. The stasis is the constant predisposing factor for venous thrombosis. Venous stasis, delivery, preeclampsia, and sepsis contribute to endothelial cell injury. The synthesis of clotting factors is markedly enhanced during pregnancy and favor coagulation. The risk factors are cesarean delivery, cesarean hysterectomy, diabetes mellitus, hemorrhage and anemia, hyperemesis, immobility, prolonged bed rest, multifetal gestation, multiparity, preeclampsia, puerperal infection, and stillbirth. The thrombophilias and their complication in pregnancy include spontaneous miscarriages, fetal death, preeclampsia, underweight babies, preterm babies, or placental abrasion. Thrombophilias, there are several regulatory proteins as inhibitors in the coagulation cascade. Inherited or acquired deficiencies of these inhibitory proteins are collectively referred to as thrombophilias. These can lead to hypercoagulopathy and recurrent venous thromboembolism. Inherited thrombophilias. Patients with inherited thrombophilic disorders often have a family history of thrombosis. These mutations are also found in up to half of the patients who present with venous thromboembolism before the age of 45 years, particularly in those whose event occurred in the absence of well-recognized risk factors. Of greatest significance is a family history of sudden death due to PTE or history of multiple family members requiring long-term anticoagulation therapy. Antithrombin deficiency, synthesized in liver, one of the most important inhibitors of thrombin and inactivates thrombin and factor A. Antithrombin deficiency may result from hundreds of different mutations that are almost always autosomal dominant. Type 1 deficiency results from reduced synthesis of biologically normal antithrombin, and type 2 deficiency is characterized by normal levels of antithrombin with reduced functional activity. Homozygous antithrombin deficiency is lethal. Heterozygous deficiency affects approximately 1 in 2,500 individuals. It is the most thrombogenic of heritable coagulopathies. The risk of thrombosis correlates with the degree of deficiency. Antithrombin deficiency is associated with a 25 to 50-fold higher relative risk of VTE in general population and 6-fold increase in thromboembolic complications during pregnancy. Protein C deficiency: when thrombin is bound to thrombomodulin on endothelial cells of small vessels, its procoagulant activities are neutralized. This binding also activates protein C, a natural anticoagulant. More than 160 different autosomal dominant mutations for protein C has been described. Prevalence of heterogeneous protein C is 2 to 3 in 1,000 patients, associated with 6 to 12-fold higher risk of pulmonary thromboembolism. Homozygous protein C deficiency may cause fatal neonatal purpura fulminans. Lastly, sepsis can also result in purpura fulminans in the adult with heterozygous protein C deficiency. Protein S deficiency: this circulating anticoagulant is activated by protein C, which enhances the capacity of protein S to inactivate factors 5A and 8A. Protein S deficiency may be caused by more than 130 different mutations with an aggregate heterozygous prevalence. Protein S deficiency may be measured by antigenically determined free, functional, and total S levels. All three decline substantially during normal gestation. Thus, diagnosis in pregnant women and in those taking OCPs is difficult. Factor V LEIDEN mutation: this is the most prevalent of the known thrombophilia syndromes and is characterized by resistance of plasma to the anticoagulant effects of activated protein C. There are several mutations that create this resistance, but the most common is factor V LEIDEN mutation. This missense mutation results from a substitution of glutamine for arginine at position 506 in the factor V polypeptide. As a result, activated factor V is neutralized approximately 10-fold more slowly by activated protein C, leading to enhanced thrombin generation. Heterozygous inheritance of factor V LEIDEN is the most common heritable thrombophilia. Women who are heterozygous for factor V LEIDEN account for approximately 40% of venous thromboembolism cases during pregnancy. Pregnant women who are homozygous without a personal or family history have a 1 to 4% risk of venous thromboembolism. Diagnosis during pregnancy is performed by a DNA analysis for the mutant factor V gene. Prothrombin G2210A mutation: this missense mutation is the prothrombin gene leads to excess accumulation of prothrombin, which may be converted to thrombin. Silver and co-workers in 2010 tested nearly 4,200 women for this mutation. 3.8% women carries the mutation, and only one of those was homozygous. Carriers had similar rates of pregnancy loss, preeclampsia, fetal growth restriction, and placental abrasion compared with non-carriers. Hyperhomocystinemia: the most common cause of elevated homocysteine is C667T thermolabile mutation of the 5,10-methylene tetrahydrofolate reductase enzyme. Inheritance is autosomal recessive. Elevated homocysteine levels may also result from deficiency of one of the several enzymes involved in methionine metabolism and from correctable nutritional deficiencies of folic acid, vitamin B6, and B12. Protein Z is a vitamin K dependent protein that serves as a cofactor in factor 10A inactivation. Studies have found that low protein Z levels are associated with an elevated thromboembolism risk also in non-pregnant patients and may be implicated in pathogenesis of poor pregnancy outcomes. Acquired thrombophilias, antiphospholipid syndrome: this prothrombotic disorder can affect both the venous and arterial circulations. The deeper veins of the lower limbs and the cerebral arterial circulation are the most frequent sites for venous and arterial thrombosis. Besides thrombosis, the major side effect of APS are adverse obstetrical outcomes. Criteria for antiphospholipid syndrome include at least one otherwise unexplained fetal death at or beyond 10 weeks, at least one preterm birth before 34 weeks of gestation because of eclampsia, severe preeclampsia, or placental insufficiency, at least 3 unexplained consecutive spontaneous abortions before 10 weeks. Testing for antiphospholipid antibodies should be performed in women with an unexplained arterial or venous thromboembolism or a history of 1 fetal loss or 3 or more recurrent embryonic or fetal losses. Antiphospholipid positivity testing confers a worse prognosis for pregnancies complicated by HELLP syndrome. These patients should be tested for the presence of three factors: lupus anticoagulant, anticardiolipin, immunoglobulin G and M antibodies, anti-beta-2 glycoprotein, IgG and IgM antibodies. If any of these are positive, confirmatory tests are performed 12 weeks later. Heritable thrombophilias and acquired thrombophilias with the preferred test method. Antithrombin deficiency, we can do heparin cofactor activity. Protein C deficiency, chromogenic activity is the preferred test method. Protein S deficiency, free protein S antigen is the preferred test method. Factor V LEIDEN deficiency, activated protein C resistance after pre-dilution of test plasma in factor V, depleted plasma or DNA based can be done. Prothrombin G20G10A deficiency, DNA based test can be done. In lupus anticoagulant, clotting based test can be done. And anticardiolipins, immunologic assays of IgG and IgM anticardiolipin can be performed. Anticoagulation treatment for DVT or PTE with triple positive antiphospholipid syndrome. People with confirmed proximal DVT or PTE and an established diagnosis of triple positive APS, low molecular weight heparin concurrently with a vitamin K antagonist for at least 5 days or until the INR is at least 2 in 2 consecutive readings, followed by a vitamin K antagonist on its own. Treatment failure can be checked by adherence to the anticoagulation treatment, address other sources of hypercoagulability, increase the dose of anticoagulant, or change to an anticoagulant with a different mode of action. Cerebral sinus venous thrombosis. CSVT is any thrombosis occurring in intracranial veins and sinuses, which is a rare disorder affecting 5 persons per million per year with huge regional variations. The prevalence of CSVT in Indian population is about 4.5 of 1,000 obstetric admissions. The widespread use of neuroimaging now allows for early diagnosis and changed our approach towards this disorder. It has usually favorable outcome with a case fatality rate of less than 10%. CSVT associated with pregnancy and puerperium has a more acute onset and better prognosis than thrombosis due to other causes. The diagnosis of CSVT is commonly overlooked or delayed because of the diversity of the clinical symptoms, modes of onset, and neuroimaging signs. Pregnancy, by virtue of its hypercoagulable state, is a known risk factor for CSVT. Studies have shown that CSVT in pregnancy should not contraindicate further pregnancies. The occlusion of major sinus leads to development of intracranial hypertension because of an impaired absorption of cerebrospinal fluid. Because there is no pressure gradient, there is no ventricular dilatation or any hydrocephalus. Significant risk was associated with use of oral contraceptive pills, cesarean delivery, increasing maternal age, presence of comorbid conditions like hyperemesis, intercurrent infection, and maternal hypertension. CSVT has a wide spectrum of clinical manifestations and modes of onset that may mimic many other neurological disorders and lead to frequent misdiagnosis or delay in diagnosis. Headache is the most common symptom. It may be related to increased intracranial tension and associated with papilledema in chronic cases. Headache can be the only symptom and can be of the thunderclap type, mimicking subarachnoid hemorrhage. Transient focal neurological deficits mimicking transient ischemic attacks can be seen. Long-lasting focal neurological deficits due to venous infarction leading to stroke of intracerebral hemorrhages. Rare clinical presentation of CSVT are migraine with aura, isolated psychiatric disturbances, pulsatile tinnitus, isolated or multiple cranial nerve involvement, or subarachnoid hemorrhage. The aim of diagnosis is the imaging of the occluded vessel or the intravascular thrombus. The gold standard is the combination of MRI, which localizes the thrombus, with MRV, which shows the non-visualization of the same vessel. Brain imaging can be normal in up to 25% of patients. Lumbar punctions is not useful in establishing the diagnosis of CSVT, although abnormalities are commonly found like raised pressure, pleocytosis, increased red cells, or raised proteins. The CT image of the CSVT shown here, we can see the infarction. This is the MRV image showing the thrombus in the vessel. Treatment of CSVT include anticoagulation therapy is a cornerstone in its management. Heparin anticoagulation is a time-honored treatment and is advocated in all cases of CSVT, irrespective of the etiology. With IV administration of unfractionated heparin, anticoagulation is rapidly achieved. The dose is variable and adjusted to maintain the APTT at 1.5 to 2 times normal. It is started at 5,000 units given as IV bolus and followed by continuous infusion of 1,000 units per hour. Subcutaneous route is also used, but unreliable bioavailability and delayed onset are the side effects. To overcome the drawbacks of unfractionated heparin, low molecular weight heparin are now the choice preparations for anticoagulation. They have a more reliable dose response, pharmacokinetics, and a reduced propensity for the platelet inhibition seen with standard heparin. Preparations like enoxaparin, dalteparin, tisaparin, and others are widely used for the treatment for CSVT. They are administered once daily with minimal side effects. Women with raised intracranial tension show improvement with mannitol or glycerol therapy, sedation, raising the head end of the bed, and hyperventilation. Steroids have found to be having no role in management even in patients with parenchymal lesions. Women who develop seizures should receive anti-epileptic drugs. Long-term management include, after the acute stage, heparin should be replaced by oral anticoagulation, and considering the evidence in DVT, warfarin should be started for 6 to 12 months, aiming at INR of 2 to 3. The goal is to prevent any recurrence or any other venous thrombosis and pulmonary embolism. Deep vein thrombosis. During pregnancy, most venous thrombosis are confined to the deep veins of the lower extremity. Most of these are located in the iliofemoral and iliac veins without involvement of the calf veins. Signs and symptoms vary depending on the degree of occlusion and the intensity of the inflammatory response. Classically, thrombosis involving the lower extremity is abrupt in onset, and there is pain and edema of the leg and thigh. Calf pain, either spontaneous due to Achilles tendon stretching, called as Homan sign, may be caused by a strained muscle. 30 to 60% of women with a confirmed lower extremity acute deep vein thrombosis have an asymptomatic pulmonary embolism. Symptoms of the blood clot include throbbing or cramping pain, swelling, redness and warmth in a leg or arm, sudden breathlessness, sharp chest pain may be worse when you breathe in, cough or coughing up blood can be seen. Diagnosis, clinical diagnosis of DVT is difficult without testing and is confirmed only in 10% of cases. The left clinical prediction rule was derived and internally validated by Chan et al. In 2009 among 194 pregnant women investigated for a suspected DVT. This rule combines three variables: some symptoms in the left leg, scarf circumference difference of 2 centimeters or over, and a first trimester presentation. They found no DVT among 46% women with none of the left criteria, but in 7 of the 105 women with at least one left criteria. Optimal management of venous thromboembolism during pregnancy has not undergone major clinical study to provide evidence-based practices. Anticoagulation is initiated with either unfractionated heparin or low molecular weight heparin. Although either is acceptable, most recommended is low molecular weight heparin. American Society of Hematology recommends preferential use of low molecular weight heparin during pregnancy because of their better bioavailability, longer plasma half-life, more predictable host response, reduced risk of osteoporosis and thrombocytopenia, and less frequent dosing. These anticoagulant regimens, prophylactic low molecular weight heparin, enoxaparin 40 mg subcut can be given once daily, dalteparin 5000 units, nidroparin 2850 units, tinzaparin 4500 units. For therapeutic low molecular weight heparin, enoxaparin 1 mg per kg every 12 hours, dalteparin 200 units per kg once daily, tinzaparin 175 units, and dalteparin 100 units per kg can be given. For prophylactic unfractionated heparin of 5000 to 7000 units subcut every 12 hours in first trimester, 7,000 to 500 to 10,000 units subcut every 12 hours in second trimester, 10,000 units subcut every 12 hours in the third trimester unless the APTT is elevated. So adjusted dose also can be given if for therapeutic unfractionated heparin, 10,000 units or more subcut every 12 hours in doses adjusted to target APTT in the therapeutic range 1.5 to 2.5, 6 hours after injection. In postpartum anticoagulation, prophylactic, intermediate, or adjusted dose of low molecular weight heparin for 6 to 8 weeks as indicated. Oral anticoagulants may be considered postpartum based upon planned duration of therapy, lactation, and patient preference. The duration of full anticoagulation varies, and no studies have defined the optimal duration for pregnancy-related thromboembolism. In non-pregnant patients, evidence supports a minimum treatment of 3 months. American College of Obstetrics and Gynecology recommends therapeutic anticoagulation for 3 to 6 months, followed by intermediate or prophylactic therapy for the duration of pregnancy and the postpartum period. If the woman is not breastfeeding, direct acting oral agents can be considered. Graduated compression stockings can be continued for 2 years after the diagnosis of to reduce the incidence of post-thrombotic syndrome. Symptoms include chronic leg paresthesia or pain, intractable edema, skin changes, or leg ulcers. Unfractionated heparin. This agent shall be considered for the initial treatment of thromboembolism and in situations in which delivery, surgery, or thrombolysis may be necessary. Unfractionated heparin can be administered by one of two alternatives: initial IV therapy followed by adjusted dose subcutaneous UFH given every 12 hours, or twice daily adjusted dose subcutaneous with doses adjusted to prolong the APTT into the therapeutic range 6 hours post-injection. For IV therapy, several protocols are accepted. In general, UFH is used in initiated as a bolus of 70 to 100 units per kg, which is 5,000 to 10,000 units. This is followed by continuous IV infusion beginning at 1,000 units per hour or 15 to 20 units per kg per hour. This infusion rate is titrated to achieve an APTT to at least 1.5 to 2.5 times control throughout the dosing interval. For women with lupus anticoagulant, APTT does not accurately assess heparin anticoagulation, and thus anti-factor 10A levels are preferred. Low molecular weight heparin does not cross placenta. They exert their antithrombin activity by activating antithrombin. UFH have equal activity against factor 10A and thrombin, whereas low molecular weight heparin has greater activity against factor 10A than thrombin, has more predictable anticoagulant response and fewer bleeding complications than UFH because of their bioavailability, longer half-life, dose-dependent clearance, and decreased interference with platelets. Low molecular weight heparin compounds are cleared by kidneys and must be cautiously used when there is renal dysfunction. Pulmonary embolism causes approximately 10% of maternal but relatively uncommon during pregnancy and the puerperium. 70% gravidas present with pulmonary embolism have associated clinical evidence of DVT. 30 to 60% of women with a DVT will have a coexistent silent PTE. Mechanism include cutaway view embolus breaking off and traveling up towards the heart and lungs in the lower extremities. Blood clots occluding the right and left pulmonary arteries from the heart also can be seen. Symptoms include dyspnea, chest pain, cough, syncope, and hemoptysis. Other predominant clinical findings typically include tachypnea, tachycardia. Right axis deviation and T-wave inversion in the anterior leads can be evident on the ECG. In most cases, chest X-ray is normal. Although most women are hypoxemic, a normal ABG analysis does not exclude PTE. Approximately a third of young women have a PO2 values of more than 80. Thus, the alveolar arterial oxygen tension difference is a more useful indicator of disease. More than 86% of patients with acute PE will have alveolar arterial difference of more than 20 mmHg. Massive and submassive, defined as embolism causing hemodynamic instability, these account for 5 to 10% of cases. Acute mechanical obstructions of the pulmonary vasculature causes increased vascular resistance and pulmonary hypertension, followed by acute right ventricular dilation. Submassive embolism is diagnosed when there is right ventricular dysfunction. The mortality rate is 25%, which compares with the 1% without such dysfunction. It is important in these cases to infuse crystalloids carefully and to support blood pressure with vasopressors. Aggressive IV fluid infusion has been associated with worsening right ventricular dysfunction. Diagnosis, erroneously assigning a diagnosis of PTE to a pregnant woman is also fraught with problems. It unnecessarily exposes the mother and fetus to the risk of anticoagulation treatment and will impact delivery plans, future conception, and thromboprophylaxis during subsequent pregnancies. Therefore, the investigation should aim for diagnostic certainty. Suspected acute pulmonary embolism in a pregnant patient, we order a D-dimer test and assess the presence of 3 years criteria. Clinical signs of deep vein thrombosis, hemoptysis, pulmonary embolism as the most likely diagnosis. If there's a years criteria, see for the clinical signs of deep vein thrombosis, do a compression ultrasonography of symptomatic leg. If the compression ultrasonography is abnormal, then initiate anticoagulant treatment. If there is a normal compression ultrasonography, look for if there is no years criteria and the D-dimer is less than 1,000, pulmonary embolism is ruled out, withhold anticoagulation treatment. If there is no years criteria and D-dimer is more than or equal to 1,000, perform CT pulmonary angiogram, initiate anticoagulation treatment if CTPA indicates pulmonary embolism, or look for if the 1 to the 3 years criteria and D-dimer is less than 500, then pulmonary embolism is also ruled out, withhold anticoagulation treatment. If you have 1 to 3 years criteria positive and D-dimer is more than or equal to 500, go for CTPA Initiate anticoagulant treatment if CTPA indicates pulmonary embolism. Diagnosis of PTE follows the same algorithm as for DVT. ECG is useful to detect other conditions that mimic PTE, such as acute MI, pericardial tamponade, aortic dissection. Further imaging with CT, MRI, or ventilation perfusion lung scanning confirms the diagnosis. American Society of Hematology recommends lung scanning as the first-line diagnostic tool. The CTPA image of the pulmonary thromboembolism. Here also you can see the thromboembolism. Management includes vena cava filters. A woman who has very recently suffered a PTE and who must undergo C-section presents a serious problem. Reversal of anticoagulation may be followed by another embolus and surgery. While fully anticoagulated frequently results in life-threatening hemorrhage or troublesome hematomas. In these cases, placement of vena cava filter should be considered before surgery. Such filters can also be used following massive emboli in patients who are not the candidates for thrombolysis. The device is inserted through jugular or femoral vein and can be inserted during labor also. Thrombolysis and embolectomy. Compared to heparin, thrombolytic agents provide more rapid lysis of pulmonary clots and improvement of pulmonary hypertension in life-threatening cases. In one study, a non-pregnant patient receiving heparin for an acute submassive PE, those receiving the alteplase has a lower risk of death and treatment escalation, and the risk of recurrence is significantly lower in patients receiving thrombolytic agents and heparin compared with heparin alone. Surgical embolectomy is uncommonly indicated. The thromboprophylaxis goes for if there is the prior single VT. If there's a risk factor of no PT, then they ask for, American College of Gynecology asks for only surveillance. And in the pregnancy and postpartum, they have different regulations and recommendations. In postpartum, prophylactic heparin also can be started if there are additional risk factors. If the pregnancy or estrogen related, or if there is a pregnancy, then prophylactic heparin can be started. In postpartum also prophylactic heparin can be started. If there is associated risk, low risk for thrombophilia during pregnancy, prophylactic or intermediate dose of heparin can be started. In postpartum also prophylactic and intermediate dose of heparin can be started. If there are 2 or more prior venous thromboembolism with or without thrombophilia, if the patient is not receiving long-term anticoagulation during the pregnancy, intermediate or therapeutic dose heparin can be started. If the patient is receiving long-term anticoagulation, therapeutic dose of heparin can be started. In the postmortem, same intermediate or therapeutic dose of heparin can be started. If the patient has no prior venous thromboembolism and the patient has no thrombophilia, just we can surveillance the patient. No need to start any heparin or anticoagulation. And the postmortem also, patient can be put on surveillance, or if you see the patient needs a prophylactic heparin, you can start if the patient has additional risk factors. If the patient has a high risk of thrombophilia, you can start with prophylactic dose of heparin, and in the postpartum also you can start with prophylactic or intermediate dose of heparin. If the patient has a positive family history of venous thromboembolism and low risk of thrombophilia, so if the thrombophilia it is the low risk, then you can put the patient on surveillance, or you can start a prophylactic dose of heparin. In the postpartum also, prophylactic dose of heparin can be started. If the patient has a compound heterozygous thrombophilia, prophylactic or intermediate dose of heparin can be started. And in the postpartum also, prophylactic or intermediate dose of heparin can be started. If there are antiphospholipid antibodies, if there is a history of venous thromboembolism, prophylactic heparin plus a low dose of aspirin can be started. In the postpartum phase also, prophylactic heparin can be started. If there is no prior venous thromboembolism, surveillance or prophylactic heparin dose can be started in the patient with recurrent pregnancy loss or stillbirth. In the postpartum also, prophylactic heparin dose can be started with low dose aspirin for 6 weeks with recurrent pregnancy loss or stillbirth. Thromboprophylaxis guidelines for women undergoing C-section. American College of Gynecology recommends pneumatic compression devices for all pharmacological prophylaxis for risk factors. If there are risk factors and the risk factors are not defined, and individual therapy can be given. Pneumatic compression devices for all prophylactic low molecular weight heparin can be given. Intermediate dose of low molecular weight heparin can be started, and individualized therapy can be given for the patient. To look for risk factors are history of venous thromboembolism, thrombophilia without a history of venous thromboembolism, class 3 obesity with a thrombophilia, and the combination of all the above factors. Royal College of Gynecology recommends prophylactic use of low molecular weight heparin for 10 days. The risk factors can be cesarean during labor, BMI of more than 40, or medical comorbidities, or 2 or more of the following: age more than 35, parity more than 3, obesity, smoker, varicose veins, systemic infection, preeclampsia, preterm delivery, stillbirth, operative vaginal delivery, and prolonged admission. It also recommends prophylactic low molecular weight heparin for 6 weeks with risk factors of prior VT, high risk thrombophilia, low risk thrombophilia, and family history of venous thromboembolism, and antenatal low molecular weight therapy. Warfarin compounds, vitamin K antagonists are generally contraindicated because they readily cross the placenta and cause fetal death and malformation from hemorrhages. Their sole antepartum use is in women with heart valve. These compounds do not accumulate in breast milk and are safe during breastfeeding. Postpartum venous thrombosis is usually treated with IV heparin and oral warfarin initiated simultaneously. Initial dose of warfarin is 5 to 10 mg for the first 2 days. Subsequent doses are titrated to achieve an INR of 2 to 3. To avoid paradoxical thrombosis and skin necrosis from the early antiprotein C effect of warfarin, these women are maintained on therapeutic doses of unfractionated heparin or low molecular weight heparin for 5 days and until the INR is in a therapeutic range for 2 consecutive days. Treatment in purpura may require larger doses of anticoagulant. Direct acting oral anticoagulants. Of these newer oral anticoagulants, dabigatran inhibits thrombin and rivaroxaban, and apixaban inhibits factor 10A. These agents are becoming drugs of choice for non-pregnant subjects with thromboembolism. Dabigatran crosses the placenta. However, it is unknown that any of these agents are excreted in breast milk. The call for a clinical antidote to NOAC is thus urgent. Ongoing clinical trials demonstrated promising results for specific antidotes that directly neutralize the actions of NOACs. Idarucimab for dabigatran, and andexanet alpha for factor 10A inhibitors, and aripazine as a universal NOAC antidote. Thrombotic microangiopathies. Although not a primary disorder, some degree of thrombocytopenia accompanies the thrombotic microangiopathies, which include thrombotic thrombocytopenic purpura, hemolytic uremic syndrome. These are characterized by thrombocytopenia, microangiopathic hemolysis, and microvascular thrombosis. Their similarities to HELLP syndrome allude to their obstetrical ramifications. Clinically, they frequently are indistinguishable. Inherited or idiopathic TTP is thought to be caused by antibodies to a plasma deficiency of ADAMTS13. HUS is usually from endothelial damage incited by viral or bacterial infections and is seen primarily in children. Substantial number of all cases are pregnancy related. With TTP, intravascular platelet aggregation simulates a cascade that leads to end organ failure. There is endothelial activation and damage. Elevated levels of unusually large multimers of von Willebrand factor are identified in TTP. Microthrombi of hyaline material containing platelets and fibrin within arterioles and capillaries when sufficient in number or size produce ischemia or infarction. ADAMTS13 enzyme activity declines during pregnancy by up to 50%. Levels drop even further with preeclampsia and especially HELLP syndrome. This is constant with prevailing opinions that TTP is more commonly seen during pregnancy. Moderate to severe hemolysis is a rather constant feature of thrombotic microangiopathies. There is seldom severe with preeclampsia even when complicated by HELLP syndrome. Differential factors between HELLP and thrombotic microangiopathies. Sometimes it is very difficult to differentiate between these. Thrombocytopenia is mild to moderate in HELLP syndrome with moderate to severe in thrombotic microangiopathies. Microangiopathy hemolysis is mild in HELLP syndrome, severe in thrombotic microangiopathies. ADAMTS13 deficiency and DIC is mild, where ADAMTS deficiency is severe in thrombotic microangiopathies. DIC is also mild in both. Transaminitis moderate to severe in HELLP syndrome and none to mild in thrombotic microangiopathies. Treatment is delivery in HELLP syndrome. In thrombotic microangiopathies, we can go for plasmapheresis. Thrombotic microangiopathies are characterized by thrombocytopenia, fragmentation, hemolysis, and organ dysfunction. TTP has a pentad of thrombocytopenia, hemolytic anemia, fever, renal impairment, neurological abnormalities. HUS typically has more profound renal involvement and fewer neurological aberrations. Thrombocytopenia is usually severe, but fortunately, even with very low platelet counts, spontaneous severe hemorrhage is uncommon. Microangiopathic hemolysis is associated with moderate to marked anemia, and erythrocyte transfusions are frequently necessary. The blood smear shows erythrocyte fragmentation and schizocytosis. Reticulocytes and nucleated red blood cells counts are increased, LDH levels are high, and haptoglobin concentrations are decreased. Consumptive coagulopathy, although common, is usually subtle and clinically insignificant. Cornerstone for treatment of TTP is plasmapheresis with fresh frozen plasma replacement along with glucocorticoids. Plasma exchange removes inhibitors and replaces ADAM-TS enzyme. Treatment with caplacizumab, the anti-von Willebrand factor immunoglobulin, inhibits the interaction between the large von Willebrand factor multimers and platelets. Red cell transfusions imperative for life-threatening anemia. Treatment is usually continued until the platelet count is normal for 2 days. Unfortunately, relapses are common. Long-term sequelae such as renal impairment can develop. Treatment for pregnancy-associated HUS, which is complement-mediated, is isoluzumab, the anti-C5 humanized monoclonal antibody. The take-home message is pregnancy is in hypercoagulable state. Compression of veins is caused by enlargement of uterus, rendering patients to stasis of blood, leading to thrombosis. Synthesis of clotting factors is enhanced during pregnancy. Inherited or acquired protein deficiency may lead to hypercoagulability and recurrent DVT. Antithrombin deficiency also has a higher risk of DVT and multifold risk in pregnancy. Protein Z is a vitamin K dependent protein that serves as a cofactor in vitamin 10A inactivation. Antiphospholipid syndrome can affect both arterial and venous system of the deeper veins of lower limbs, and cerebral arterial system are also affected. Confirmed proximal DVT or PT and established diagnosis of triple positive APS, low molecular weight heparin can be started with vitamin K antagonist for at least 5 days until the INR is 2. Then it can be followed by vitamin K antagonist on its own. CSVT associated with pregnancy and puerperium has a more acute onset and it has a better prognosis. CSVT in pregnancy should not contraindicate further pregnancies. Low molecular weight heparin are now the choice preparations for anticoagulation. Enoxaparin, dalteparin, tizapatide are also used widely. 30 to 60% of women with a confirmed lower extremity acute deep thrombosis have an asymptomatic pulmonary embolism. It is preferred to use low molecular weight heparin during pregnancy because of the better bioavailability. It is recommended that therapeutic anticoagulation is given for 3 to 6 months, followed by intermediate or prophylactic therapy during pregnancy and the postpartum period. Women with lupus anticoagulant APTT does not accurately assess heparin anticoagulation. Thus, anti-factor 10A levels are preferred for use. Low molecular weight heparin does not cross the placenta. Dabigatran crosses the placenta. The alveolar arterial oxygen tension is the more useful indicator in the PT. Massive and submassive PT is defined as hemodynamic instability with right ventricular dysfunction. It is important to monitor crystalloid infusion as it hampers right ventricular dysfunction. Factors reduces cost of therapy and use of blood components in massive PPS. Vena cava filters are indicated with the risk of reversal of anticoagulation is not there. Risk of death or treatment escalation and the risk of recurrence is significantly lower in patients receiving thrombolytic agents and heparin compared with just heparin alone in PTE. Dabigatran inhibits thrombin, rivaroxaban inhibits and apixaban inhibits factor 10A. Reversal of heparin by protamine sulfate 1 mg per 100 units heparin with a maximum dose of 50 mg can be given. Vitamin K antagonists are the sole antepartum used in women with heart valve and are safe during breastfeeding. Edarisumab for dabigatran, adnexate alpha for factor 10A inhibitors, and aripiprazine as a universal NOAC antidote can be given. Elevated levels of unusually large multimers of von Willebrand factor are identified in TTP. ADAM-TS13 levels are low in pregnancy. Their levels further drop with preeclampsia and HELLP syndrome. Monoclonal antibodies are newer entrants in treatment of TTP and HUS. PPH is a life-threatening vaginal bleeding after delivery. PPH is the leading cause of morbidity and mortality in childbirth. One should be cautious of its immediate and relative causes, risk factors, and immediate action must be taken to stop the bleeding. TEG has emerged in many settings as a reliable means to urgently population status in pregnancy. Thank you, sir.
Thank you, Dr. That was an exhaustive presentation. Only 2 points I would like to add. One, the exact standardization of the tests of coagulation in pregnancy is not very clear still. What is the cutoff for INR for therapeutic anticoagulation? What is the cutoff of APTT for standardization? We don't know yet. So the use of point of care testing seems to be the only solution to know whether we are under or over coagulating these patients in the pregnant state. The other point I would like to add is the importance of the retrograde endovascular balloon occlusion device, that is a REBOA. which has come in as a major prevention for patients with pelvic trauma who are bleeding. That is also used in pregnancy. Internal iliac ligation was the standard of care, but it is a technical procedure. Not many, it requires a little bit of a learning curve. So the Ribova could be an alternative. So that is something which should be considered in these patients. So next week, we will start our series on trauma, and the initial approach to a trauma patient will be the first of those series that will be done by Dr. Harini and guided by Dr. Chandresh. Till then,